Hello and happy Teach Me Tuesday. Welcome to February. And February is known as Heart Month. It's the month of hearts and red and all this wonderfulness. And in the NICU, we talk about hearts and we think about our congenital heart diseases. We don't always think about, in adults, we're always like, oh, let's be heart healthy. Let's exercise and get our blood pressure under control and all those things, which is great. But in the NICU, we're more talking about some of our congenital heart diseases. So this is going to be a 4-part series. We're just going to cover 4 different heart diseases. And today we're going to start with coarctation of the aorta. This is actually one of my favorite ones. We do a cardiac simulation in our NICU residency program, and it's actually my favorite one. I love talking about coarcs. I love talking about the heart flow, the blood flow through the heart. It's helped me understand so much better what's going on. So let's dive in. So when we're reviewing coarctation of the aorta, which I'm going to call coarc moving forward, it's just easier for me. It's that congenital heart disease, which is characterized by a narrowing or constriction of the aorta. So that's that main artery that carries oxygen-rich blood out to all the parts of the baby. So if you think of a pipe, my parents had a tree branch grow through their pipe last year, had to do all this yard work to get to it. And so there was this constriction, there was an obstruction in there. That's what a coarc is. It's a tightening that causes an obstruction throughout the aorta so that the blood cannot go through. And when this happens, and you think about what's pumping the blood into the aorta, which is that left ventricle, the left ventricle in and of itself is going to have to pump even harder. So in utero, we don't always see coarcs because of the PDA. The PDA is allowing blood to go in a different direction. It's allowing blood to maybe filter through. So it looks like there's this great blood flow through your entire aorta. And then as the PDA closes in an extrauterine transition, all of a sudden we're having these symptoms of a constriction or coarctation. So this heart disease is pretty easy to treat. It's a pretty, if you're going to pick one, this is one of those kind of easier ones to treat, and the babies don't usually have that many lifelong effects. It's still a big deal, especially if it's a surprise diagnosis and maybe at discharge or after discharge, it can be very hard for families. So in today's slides, we are going to review the normal blood flow through the heart. We will not do this every week, but we're just going to kind of recap it here so we can talk about what's going on. So if you think about that blood flow through the heart, when you think about this, it's fascinating that any of us are born with a normal functioning heart, because the heart is developed between 5 and 6 weeks gestation. Some women don't even know they're pregnant, and yet this is already happening, and it happens perfectly the majority of time, the vast majority of time. Wild. So you have your superior and your inferior vena cava, where the blood is coming into the right atrium. It then goes into the right ventricle, goes up into those pulmonary arteries. Remember, arteries are away. So it's going away from the heart and into the lungs. It's going to drop off the CO2, pick up the oxygen. It's going to become red. It's going to go into the left atrium, down into your left ventricle, up and out your aorta. So if we look here at our aorta, something that's really helped me over the years is to remember that whatever color the aorta is going to be the color of the baby. And that helps differentiate between cyanotic and acyanotic heart defects. So here with this normal, lovely heart functioning in a nice, normal way, you have a very red aorta. So you've got this well-oxygenated blood going out. So it's going to go up here. We've got our little branches that feed our right arm, our preductal area, our brain, all these lovely things. And it's going to go into your descending aorta and down and out into the body. So where our little constriction is going to kind of affect what's going on. But in general, the blood that's going out the aorta is going to be oxygenated. So we do not consider this a cyanotic heart defect. So if we compare this normal heart with our coarc, you can see over here our aorta looks like beautiful and thick and wide open. And over here in the coarctation, we have this narrowing. In both of these pictures, we see a red aorta. That means we are still getting red blood and oxygenated blood out. It's just that there's this blockage in the way. And when there's a blockage, again, that left ventricle is going to have to work so hard. So depending on the location of the narrowing, it really depends on what is going to happen with the baby. Most commonly, it occurs near the aortic arch before the descending aorta, just beyond the left subclavian artery. So this is that third branch. It's usually happening after it. Often this is also, again, the location of your ductus arteriosus. So while that is open, you can see that in utero, you can't easily tell, especially if it's a mild constriction, that the baby has a coarc. So the effect on blood flow is, again, that narrowing restricts the blood flow. The pump's going to have to work harder to overcome that obstruction. So the symptoms that we see in these babies are really going to vary depending on that narrowing. And if you have a complete narrowing and your PDA closes, you can imagine that we're then not getting blood flow, and that is an emergency. Some of the more minor cases, you might start seeing desaturations. We've had babies that have failed a car seat trial in the mom-baby unit and come down, ended up with an echo, and there was the coarc, failed their CCHD screening, so that right wrist and a lower extremity pulse oximetry were different enough that it warranted further examination. These babies often have difficulty feeding, poor growth, rapid breathing, pale or cool extremities. Again, if we can't get the oxygenated blood to the lower extremities, you can imagine why they would be pale or cool. High blood pressure. A major point here is going to be the difference in the blood pressure between the upper extremities and the lower extremities. So if you're doing 4 extremity blood pressures, you're going to note differences there. That poor activity tolerance, so we already know that our baby's number one activity is to feed. So that eating and breathing, sucking, swallowing, breathing is going to be difficult for them. And then, of course, they may have a heart murmur. So this path to the NICU, it's not always the exact same path for every baby. So if we do have that antenatal diagnosis where there is a tight enough constriction that they can see there's going to be an issue, the baby will get a fetal echocardiogram. That will say, like, hey, this is what we're seeing. This is how severe it is. They will have a consult with cardiology. They will have a consult with NICU. Some of them may be direct NICU admissions. Some may say we're going to follow up with cardiology in 7 days. Some may say let's how the baby does at delivery. Regardless, we'll probably end up with an echo. So either in the NICU or in your special care nursery or your level, your mom-baby nursery, whatever that might be. Going to get a chest X-ray, do pre and post ductal oximetry, again with that 4 extremity blood pressure. Those are going to be those indicators to us that, hey, something is wrong, or actually we're doing okay. Now, postpartum, like we were talking about, is sometimes a baby is going to demonstrate some of these signs and symptoms, and then all of a sudden we're like, oh my gosh, we need to do more investigation. From poor feeding to the cool extremities to modeling to doing that CCHD screening and it being abnormal. And again, pretty similar things are going to happen. We're going to get an echo, we're going to get an EKG, our chest X-ray, and then of course our pulse oximetry and blood pressure and temperature control. So once the baby comes to the NICU, the steps are pretty straightforward thereafter. The echo is going to tell us so much. It is the gold standard for diagnosis of any congenital heart defect, but especially with coarc, to see how severe that constriction is. If the constriction is severe, we are going to have medical treatment. That is when the baby is going to get PGE, prostaglandins, alprostadil, whatever you call it on your unit. That is keeping the ductus open so the blood can bypass that coarctation and allow more blood to get to the lower extremities and everywhere else until we can repair. These babies may also need some diuretics, oxygen therapy, things that these babies might need just to help them in the time that they're managing prior to surgery. But again, that tight constriction, which we talked about on that previous slide, is before, if we've got our branches, and if we have our left subclavicular, and then our coarc is also where the PDA usually is located. Now, not 100% of the time, God forbid, 100% of the time. So because of that, we want to keep the PDA open to allow more blood flow to the lower extremities. And that is what PGE is going to do for us. This is going to be cardiology guiding us, looking at the echo, whether that's antenatal and looking at that fetal echo. We've had severe coarctations of the aorta where the baby comes in and we got to get that PGE started right away. And then we've had coarcs that really aren't that bad that they're probably going to get treated and after they get discharged, and then they can go to cardiology. The surgical intervention, I don't want to ever characterize any surgery as easy, but one great website that I love, that I highly recommend that you go to, is CHOP, the Children's Hospital of Philadelphia. They have a great website where it shows you like, oh, look, you just like snip this little thing out and then you just sew it back together. I'm like, no big deal. We're just going to sew that thing back together. But some of these babies just need a cardiac catheterization. So they thread the tube up, they get the balloon going in, they inflate the balloon, and it expands that narrowed section. So I have this picture here where we have just a little, patch in there. We've got a full-on graft. We have a removal, and then they just sew the descending aorta back together. Again, this stuff is fascinating. But one of those things may happen. So they may remove it, they may patch it, they may enlarge it, they may do a cardiac cath. In general, you should think to yourself, the worse it is, the tighter the constriction, the bigger the block, the bigger surgery they're probably going to need to do. And most likely that's going to be the resection with the end-to-end or graft put in. In general, those tighter ones, if there's going to be a subclavian graft, we are actually like moving things around. That's going to be your tightest of the tight. So wild, we can just kind of go in and fix this block like that. But once that happens, in general, babies do really well. So our education for our parents is really that life, for babies that have coarctation, can be relatively normal. A complete recovery is possible. There's not usually a second surgery or a second procedure. There's going to be follow-up going on with cardiology appointments. We're watching our blood pressure, watching for heart disease, might be on some medications. We're going to have a promotion of a healthy lifestyle. But in general, these children do quite well as they move throughout their life. I think that's super important to think about. If we look at this picture again, we have this narrowing. We just have to re-expand it. So going back to what is the color of the aorta? In this acyanotic, this baby still has oxygenated blood going in the right places. It's just that there's a blockage in those places. So because of that, we want to remove the blockage, and then they're pretty much going to do okay. Again, I'm not minimizing surgery. It's still a pretty big deal. But this can be a very scary diagnosis, especially if your baby is getting ready to discharge and they're getting their CCHD and their car seat trial, and then all of a sudden we're getting this, abnormal findings, maybe transferring to a NICU, getting seen by cardiology. If we know it antenatally, again, we're going to be having extra appointments, extra fetal echoes, all of these things that are going to kind of get in our way of what we consider to be a normal labor and delivery experience. Remembering that echo is the gold standard for diagnosis for this and all congenital heart defects. But once we have that echo, we'll have a better picture of what can happen. The treatment options can be pretty straightforward and are usually curative, and the baby doesn't require further surgeries. So that's coarctation of the aorta. Next week, we will cover another congenital heart disease during our month of February. So 4 diseases this month, 4 weeks. It's going to be a great month. And please comment or let me know if you have any questions. Have a great Tuesday.